Hi, this is Tom Shannon. In this presentation we'll be looking at the treatment choices for localised prostate cancer. Now, no one wants to hear that they've got prostate cancer, but when you do, instantly the thoughts turn to what to do next. And once you have a good grip on what the grade and stage of your disease is, the next thing you'll be thinking about is what type of treatment should you have and what's suitable for you. So this presentation gives you an overview of what those treatment choices are, and in other presentations we'll go into a little bit more detail about each individual treatment. Certainly one of the first thoughts should be the possibility of not having any treatment at all. Not all prostate cancers, as we've seen from previous presentations, are aggressive enough to warrant a treatment. In general terms, if you've got a life expectancy of 10 years and the prostate cancer is of a reasonably aggressive nature, then treatment should be warranted, and you should discuss this with your urologist. If we're going to treat, we're going to treat you to cure the cancer, so that means we are going to get rid of the cancer completely and we're never going to see it again. There are non-curative treatments as well, some treatments that may be able to temporise or slow the growth of the cancer and therefore keep you free of any troubles from the cancer, but you would still have prostate cancer. So let's look at these in a little bit more detail. I think it's important to say that early detection of prostate cancer really does mean that we are most often looking at curative treatments. With curative treatments, as you can see, there's a significant number of options, from active surveillance or delayed treatment through to surgical options, and the surgical options now include open and laparoscopic radical prostatectomy, either with nerve sparing or no nerve sparing. And the laparoscopic keyhole surgery can now be done either via a full laparoscopic approach, whereby the surgeon is holding the instruments that are inserted into the patient, or with robotic assistance, where a machine is holding those instruments and the surgeon drives that machine from a console situated next to the bedside. With radiotherapy, there are several different types. The standard radiotherapy is shone from the outside in what's called a four-field technique. Conformal radiotherapy aims to improve that by, instead of just treating in boxes, by making it a little bit closer to the natural curves of the prostate. IMRT is intensity modulated radiotherapy. Proton beam uses protons instead of electrons, which have some niceties to it, which we'll discuss. Brachytherapy is a treatment where the radiation is given from directly inside the prostate, and the beauty of brachytherapy is that you're giving the radiation directly where it's needed. It doesn't have to travel through other tissue first. And this can be either done by low dose rate with seed implantation or high dose rate with rods placed in and an external radiation source. There are some emerging or experimental treatments also, and these include HIFU or high intensity focused ultrasound and cryotherapy. So let's look first at active surveillance. Active surveillance is something that I would consider appropriate for patients who you might not want to treat straight away. And these can be older patients, but also younger patients with very small volume disease or low grade disease. Actually, a prerequisite of this is that the disease should not be aggressive. So these are the types of patients who may go through the 15 years, as we saw on the previous Albertson tables, and have a very low risk of death from prostate cancer. And the positives of doing this are that whilst you're being watched, it's very low risk. There's a very small chance that the disease could get away from you before you would see that. So it's most likely if the disease changes that PSA would change or a biopsy would change. There are no treatment side effects, so the problems with radiotherapy and surgery that we'll discuss in a minute you don't have to worry about. The main negatives of this, however, is that there's a small risk that the biopsy did not accurately determine what sort of disease you've got. So that means we might have thought you had a 5 or a 6 when in fact you had a 7. And if you had a Gleason 7 cancer, we wouldn't recommend this type of surveillance. Rebiopsy is often needed just to make sure, and this is often done a year after the first biopsy, and regular monitoring, and there are quite a few visits back to the doctor. But for some men this can be a very good way to manage their prostate cancer. Radical prostatectomy, as you've probably all heard of, is a surgical option, and the logic behind it's very simple. If the cancer is confined to the prostate, then removal of the prostate will cure the disease. As you can see from this diagram, the prostate sits just below the bladder, and there are seminal vesicles attached to the prostate which are also behind the bladder. And the area that we tend to resect is the prostate, the seminal vesicles, and the vas internally as well. The lymph nodes are removed on a case-by-case basis, but more often than not are left behind. The main problem with a radical prostatectomy is that there's some critical structures right next door to what you have to remove. And the nerves that supply the penis for erections run in a groove between the rectum and the prostate, and then arch up towards the sphincter. And these are all things that need to be preserved, and yet we need to take enough room on the prostate to make sure we adequately remove the cancer. If you can imagine the prostate's a ping pong ball, and you put some fairy floss along the side of it and then shrink wrap over the top of that. That's really what these nerves are like. They have to be peeled away from the prostate gland, and the prostate peeled away from the nerves in order to preserve them. So you can see why damage to the erection nerves can often occur. Another negative is that if you try and preserve those nerves when you shouldn't, sometimes cancer is actually growing into those nerves, and because of that we could leave cancer behind. At the end of the surgery, the prostate's gone, you're left with the bladder and the external sphincter, and this is sutured back together again. A catheter is placed to drain the bladder until this area heals, which is typically between 1 and 3 weeks. So the positives of radical prostatectomy is that it has a very high cure rate for confined disease. If the cancer's in the prostate, you remove the prostate, the cancer's gone. The good thing about surgery is that you have a specimen. You actually have taken the prostate out and you've given it to a pathologist. So you have definitive pathology, and it can tell you that the cancer's actually gone. So we would expect a report back soon after surgery telling you, yes, you got rid of the cancer, this is how much there was, and this is what the grade actually was. On top of that, a few weeks after surgery, you can do a PSA test. And when you repeat the PSA test, it should return to 0. Now, PSA only comes from prostate tissue. So if there's no longer any prostate tissue in the body, and therefore no longer any prostate cancer in the body, a PSA of 0 is a very reassuring thing. Follow-up after surgery is therefore quite easy, because if you do a PSA test every 6 months or so, you know absolutely there's no evidence of cancer. Now, there's no other cancer that we have such a good test after the treatment with surgery. There's a very low rate of late failure after radical prostatectomy. If the prostate's not there to cause problems, then failure should not occur. Now, failure in the first few years could occur with cells that have floated off in the bloodstream and implanted somewhere else, and for reasons we don't understand, they can flare up at a later date. But if you're beyond 5 years and your PSA has been 0 and your margins have been negative, your chance of failure is in the very low percentage points. The main negative out of surgery is that if the cancer has gone beyond what you can physically resect, then you may not get it all out. Now, this can be hard to tell before surgery, and we do x-rays and look at the PSA and the grade and stage of the prostate cancer, but in some cases, no matter how good the surgery, you can leave prostate cancer behind. Now, further treatment can be given, radiotherapy can be added on top, but you go into surgery expecting and hoping that you'll remove all of the cancer, and that doesn't always happen. Surgery carries with it some risks. It's invasive. You can have damage to the bladder, to the ureter tubes down from the kidneys, and damage to the rectum. You can have damage to the nerves that supply erections, and even the sphincter muscle that keeps continence under control. We do expect that you'll have a period of incontinence, and for most people these days this is a very short-lived problem. In some patients this can be longer, and it is sometimes hard to predict that before surgery. In most cases, if you've had bladder trouble before the radical prostatectomy, you're more likely to have bladder trouble afterwards. Impotence is common if the nerves are taken. Those nerves that are right on the prostate can be damaged, and sometimes we intentionally take them if there's a lot of cancer. Spontaneous normal erections can be difficult to achieve if those nerves are damaged. Now, prostate cancer is not good news for erections in any way. If you don't treat the prostate cancer, the erections can be damaged if the cancer invades the nerves. If you do with surgery, you can damage those nerves directly. Certainly detecting the prostate cancer early has made a huge difference in terms of our ability to preserve those nerves. And with higher grade or higher volume disease, it becomes less safe to do. The ideal patient for radical prostatectomy would be a fit man who's seeking reassurance that his cancer is gone. He should have localized disease which is likely to be cured and have many years of life expectancy. Certainly the real benefits of surgery probably start to kick in 5 to 10 years after the operation rather than in the immediate post-operative phase. The patient needs to accept the potential risks and complications which can occur, especially long-term erectile problems. With a nerve-sparing radical prostatectomy, with small volume cancers, ideally Gleason 6 or less, but some Gleason 7s, we can preserve those nerves, and newer techniques are being used all the time which cause less and less trauma to the nerves and faster recovery. But early detection of prostate cancer is by far and away the most important thing that allows us to preserve these nerves. In recent years there's been a move towards minimally invasive surgery across the board, and prostate surgery is no different. Laparoscopic radical prostatectomy has been practiced widespread since around 2000. It's a difficult procedure, and because of that, the robotic assistance has been helpful in making this a procedure that is more open to other surgeons who aren't familiar with the laparoscopic approach. The pros and cons are exactly the same as for the open surgery. The positives are that the same results can be achieved with cancer control, water control, incontinence, and impotence in experienced hands. But better results are achieved with less blood loss, shorter hospital stay, less pain, shorter catheter time, and faster return to normal activities. This is because the abdomen is filled with gas during the procedure, and therefore most of the bleeding which occurs during open surgery is prevented. The negatives of this procedure are that it is a difficult procedure to do. The male pelvis is a difficult place with limited access, and it requires a different set of skills. Now, as time goes on, more surgeons are acquiring these types of skills to do keyhole surgery, and as experience increases, what can be achieved with keyhole surgery is at least as good as what can be achieved with open surgery. It's important to know from your surgeon what his level of experience is with this type of technique, as it tends to take around 100 cases or so to achieve laparoscopically what you could achieve open previously. The robotic assistance requires an interface with a computer-driven machine, which adds a certain layer of expense, which is around $10,000 per case. The ideal patient for laparoscopic surgery would be the same patient who wants open surgery, but who wants the benefits of faster recovery, with less blood loss, less pain, faster return to work. For example, a self-employed patient. So in conclusion, radical prostatectomy does have a high cure rate with long-term 15-year results showing excellent outcomes of over 90% cause-specific and metastasis-free survival. So surgery can offer the highest cure rates in localised cancer, with PSA and pathology at 1 month, with negatives being the risks of the surgery and the fact that we cannot cure all disease if it has extended beyond the prostate. Impotence can be common, and you need to talk to your urologist about whether this would be expected. A period of incontinence will occur. This slide's looking at that T3 disease, showing disease extending beyond what can be normally physically resected at the time of surgery. If we move now to look at an overview of radiotherapy, it's important to understand how radiotherapy works. Radiation damages tumour DNA, which in itself can have a direct killing effect. If the DNA is damaged badly enough, then the cell will die. Some cells become damaged to the point where they can't function, but they remain alive, and these cells have been rendered inert. But radiation also damages the tissue structures and the tissues surrounding the tumour, and this reduces the blood supply available to the cancer. Now, cancer is not like normal tissue. It needs a big blood supply and has its own ways of inducing this big blood supply, and radiation reverses that to a large extent. Hormone treatment does increase the chance of success by reducing the tissue and tumour burden prior to radiation treatment. And the radiotherapy can damage normal cells as well as cancer cells, but the cancer cells appear to be more susceptible to them. So the aim with radiotherapy is to give the highest dose to the cancer and the lowest dose to the surrounding normal tissue. So we have external beam radiotherapy, non-conformal. It treats like a box shape. You have square beams shone from different directions. 3D conformal aims to contour around the prostate and is a better option than non-conformal treatment in the pelvis because there are some critical structures such as the rectum very close by, and the rectum is quite sensitive to radiation. Intensity modulated radiotherapy allows you to achieve very close contours around the prostate. But this is quite time and machine intensive and therefore quite an expensive treatment. Proton beam radiotherapy allows you to adjust the focal depth of the radiation also, and therefore you can adjust the dose quite closely, giving you a very conformal pattern of distribution. This is incredibly expensive and difficult, and has been used for prostate cancer, but really seems to have a role in some critical structures such as spinal cord tumours or brain tumours in children, where the area that you're trying to irradiate is quite small and you need to be precise. So there's more than one type of radiotherapy. The more conformal you are, the less damage to the surrounding tissue. But the key benefit of this is that you can actually push up the dose to the cancer. So if we look at least to most conformal, we have standard, 3D conformal, IMRT, proton beam, and HDR brachytherapy, which we'll talk about in a minute. So the positives of radiotherapy is it does have a high cure rate. We don't have to worry about it, general anaesthetics. There's less risk of damage to erections, and it damages erections in a different way. Certainly the erections seem to keep going through radiotherapy. It can often be helped along by Viagra or medication, whereas surgery tends to be a more sudden loss. If you like, it's like an accelerated gradual decline. So most men will lose their erections over time, but not until they're much older. Radiotherapy will bring that on a little faster. You're not limited by anatomical boundaries, and you can treat beyond surgical margins.
However, the negatives are that 100% cell kill is very difficult to achieve, and I think it happens rarely. What that means is it's harder to prove success, so that the PSA rarely falls to zero. The PSA can then fluctuate and move about as the prostate's still present. So a patient after radiotherapy who comes back and says, "Is my cancer gone?" we have to sit tight and say, there's no sign of it behaving in an aggressive way. It's not behaving like a cancer anymore. It's certainly well suppressed, but it's not zero, and we need to keep watching. And typically it's 1 to 2 years before any reasonable conclusion can be made about the success of treatment. If the prostate's still there, it is possible for late failures to occur, so they're far more likely with radiotherapy than they are with surgery. The complications can be hard to treat because if the radiation has damaged the rectum or the bladder, for example, then that damage can be permanent. With good, skilled radiotherapy and modern treatment techniques, the risks to the bladder and the rectum are significantly reduced. So this is a picture looking at the planning for 3D conformal radiotherapy, which allows you to shield the critical structures such as the rectum, which you see in the bottom right-hand picture, just behind the area of the prostate which is being treated. The ideal patient for external beam radiotherapy may be that older patient with localised cancer that needs treatment, who's not fit for surgery, or a patient not suitable for surgery due to more advanced disease. If the disease is aggressive, then high-dose rate brachytherapy might be a better option, as a higher dose to tissue can be achieved. The patient needs to accept the fact that they're likely to have hormonal blockade for a period of around 6 months, and this has its own side effects. So moving on to prostate brachytherapy, this is a seed, and you can see the size of this little titanium capsule, which has a hollow core which is filled with iodine-125, which is radioactive iodine. After an implant, around 120 of these are placed in a prostate, and you can imagine that these are each giving off their small dose of radiation, whereas the combined effect gives a very large dose of radiation exactly where you would like it to be. So with brachytherapy, patients usually have their legs up in the air and the seeds are placed directly into the prostate using an ultrasound in the back passage and image intensification, which is a special X-ray from above to ensure that an accurate position is achieved. The needles are held in place by a template, and a plan is followed to place the seeds directly where they are needed. The positives of this is a very high dose. It's given to the prostate of around 140 gray. This is roughly twice the dose given with standard external beam radiotherapy. It's a short procedure of around an hour with an overnight stay or a day stay, and it appears to have the lowest impact on erections. The main negatives is that it's quite labour intensive, requiring the involvement of a urologist, a radiation oncologist and a physicist to plan this. This makes it an expensive treatment, and the fact that an implant is used and left in the patient and can't be reused increases the cost. It is common to have urethral irritation for approximately 3 to 6 months, and some stinging, burning and slowing down of the waterworks. The ideal patient for prostate brachytherapy with seeds would be an older man, 65 plus, with Gleason 6 or favourable Gleason 7 disease, PSA less than 10, and perhaps with a younger wife or a man who places the importance of preserving erections above other factors. High-dose rate brachytherapy is similar to low-dose rate brachytherapy in the way it's delivered, but it's used for very different patients. It's used in combination with low-dose external beam radiotherapy and hormonal blockade. 15 to 17 rods are placed in the prostate, and a CT is then done of the rods in their position and doses calculated to give a high dose to the prostate gland. A radioactive iridium source, which can be reused for many patients, is placed down the hollow rods at predetermined points, and 3 6 gray fractions are given over 2 days. Now this compares with the standard external beam radiotherapy fraction of only 2 gray. So over a period of 2 days, 18 gray is being given, which is a very high dose, especially when it's given directly into the prostate gland. So you can see the schematic representation of covering the cancer with these rods in place. So the positives of this is it gives a very high dose to the cancer, 90 gray external beam radiotherapy equivalent. Now it's not possible to achieve this with external beam radiotherapy because of the toxicity which would occur to the back passage, the rectum and the bladder. But with the high dose rate brachytherapy protocol, we can do this with around the same toxicity as standard external beam. It's highly conformal and gives superior control over dose, with the same side effect profile as you'd see in external beam radiotherapy. It's suitable for high-risk T3 disease and can treat the seminal vesicles, something which is very hard to do with external beam radiotherapy, as these sit behind the bladder. It's certainly cheaper than seed therapy, as the radiation source can be reused. The negatives are that the patient has to be in hospital with the rods in place between each fraction, so for around 36 hours. It can't be used as monotherapy, so patients still have to have some external beam treatment, and hormone therapy is required before treatment. It's only available currently in specialist centres. And there's a risk of damage to the urethra, the water pipe below the bladder, if the template moves and radiation is given to the wrong area. Now the ideal patient for brachytherapy is usually somebody who's unsuitable for surgery because they have high-risk disease. They may have seminal vesicle invasion or an MRI or rectal examination showing the disease is beyond the prostate gland. Large volume, high-grade tumours that may have poor results from standard radiotherapy tend to be those patients we treat with brachytherapy. They also should have no evidence of metastasis, because this treatment is only treating the area of the prostate gland. If we look quickly at the experimental treatments, these do get some press at the moment, and it's important to understand them. High-intensity focused ultrasound is essentially a way of delivering heat to the prostate to kill the cancer. And cryotherapy is a way of using cold to freeze the prostate and kill the cancer. The positives of these is that they're both minimally invasive. HIFU involves placing a probe in the rectum, and a balloon is blown up around that probe through which cold water is run. A beam is then focused through the wall of the rectum onto the prostate in order to heat the prostate to the point where the cancer and the prostate are damaged. Cryotherapy is similar to high-dose rate brachytherapy in that needles need to be placed through the perineum directly into the prostate gland. They're both fairly low-risk procedures, although there is still impotence and incontinence and the possibility of damage to rectum with both of these procedures. It's likely there's less damage to erections than there is with surgery. And cryotherapy in particular can be used after radiotherapy failure, where other treatments cannot be. The main negative is that with this treatment you've got to heat or freeze the whole of the prostate gland in order to get rid of all of the cancer. And this is much harder than you would like to believe. You therefore may not cure all the cancer. And in a lot of patients what happens is the PSA will fall dramatically because a lot of the cancer and the prostate has been damaged or destroyed, but not 100%. And in the longer term, that is likely to mean that the cancer will continue unabated. It's also much harder to prove success because the PSA doesn't go to zero, and the PSA can fluctuate as the prostate remains in place. Retreatment is common, especially with HIFU, and around 20% of patients in short-term follow-up series have had a second treatment done. So therefore this may be suited for patients with insignificant disease who want to have a treatment done, but whose disease is not of such a risk to them that if the treatment were to fail to kill all the cancer, that they would be in trouble. So I'm going to leave that one there, and there are further presentations to look at in a bit more depth on each treatment. And one more slide. So the ideal patient for HIFU, older patient with low-grade disease, or a younger patient's failed radiotherapy. Cryotherapy is a patient really with a rising PSA after radiotherapy and no